Medical Affairs at Wockhardt Life Sciences. The topic for today is L20 Summit, time-tested legends along with the new research antibiotic in type 2 diabetes mellitus. And with this, I would like to share our expert panel today. We have Dr. Abdul Hamid Zargar sir, who is our chairperson, Dr. Anirban Sinha sir, who is our expert speaker, and Dr. Jessie Thomas ma'am, who would be our expert speaker. The agenda would be very fluid. After the welcome and introductions, we'll have the opening remarks and context setting by Dr. Zargar sir. Followed by that, we'll have the first topic for today, which would be insulins and SUs, the time-tested legends by Dr. Anirban Sinha sir. Then we'll have MROC in DFI, a case-based discussion with Dr. Jessie Thomas, and opening for the discussion with all faculties. With that, I take the privilege of introducing our chairperson today, Dr. Zargar sir. Sir is an Economic Times Awardee 2021 member of the High-Powered Committee on Health and Medical Education, Government of India, Vision 2035, former director and chairman of Department of Endocrinology, Sher-e-Kashmir Institute of Medical Sciences, Srinagar in Kashmir, member of the Institute Body, AIMS, New Delhi, and member of the Medical Council of India, Government of India nominee. Past president, Endocrine Society of India. Also, sir had been the editor-in-chief of the Indian Journal of Endocrinology. He has more than 200 publications in national and international journals. So we welcome you for the event. We have our first speaker, Dr. Anirban Sinha sir, who would be talking on insulins and SUs, the time-tested legends. Sir is an associate professor, Department of Endocrinology, Medical College of Kolkata, awarded as A.V. Gandhi Gold Medal for Excellence in Endocrinology in 2010, and a fellow of the American College of Endocrinology in 2015. He has multiple publications in various journals and has written book chapters like the Paramedical Care in Diabetes, RSSDI Yearbook of Diabetes 2017. He works as a study investigator in multiple clinical trials and has presented papers and participated as a faculty in various national and international conferences. Sir, we welcome you for the event. We have a second expert speaker who would be talking on MROC in DFI, a case-based discussion. Dr. Jessie Thomas, she is one of the pioneers and working and training in the diabetic foot field, podiatry, for more than 2 decades. She is trained in establishing diabetic foot clinics conducted by the World Diabetic Federation in association with DFSI since 2002. Has experience of treating over 7,000 diabetic foot cases since 1997. Her main interest lies in foot salvage in diabetic foot management. She has to her credit in establishing diabetic foot clinics in various comprehensive diabetic care centers in Mumbai. Also instrumental in starting diabetic foot clinic at SL Raheja Hospital, along with Brigadier Joe Kurian in 2003. She has also published articles in wound care journals, Journal of Evidence-Based Medicine, and Wounds International magazine. Ma'am, we welcome you for the event. And now I'll hand over the session to Dr. Zargar sir, our chairperson for today, for opening remarks and context setting. Over to you, sir.
A very good evening, dear friends and colleagues, and welcome to this L20 Summit. Today, we know that diabetes is escalating globally, and we have been talking about the emerging figures now for the last 3 decades. When I was a postgraduate, India had a diabetic population of 11.8 million people. The last study we published in Lancet was in 2016, when we postulated India had 65 million diabetics. And today we are almost approaching 80 million. Now it is not only that we have now increased number of diabetics, 11 million versus 80 millions. In terms of numbers, that alone is not true. What many times we keep on missing is that When I'm talking about 1980-81 of those 11 million, people on an average used to get diabetes at the age of 48, published data from our own country. And average life expectancy was 56 years. People would officially retire from their position at the age of 54. So glycemia or hyperglycemia had the potential of doing a damage to the body for less than a decade. Today, the same diabetes occurs on an average, published data, at the age of 32. And this 32-year-old boy or girl has a potential of living till 75th or 80th birthday. So the glycemic burden on his body would be for half a century. So it is not only the numbers that are increased, it is the duration of survival to which body's tissue would be exposed to abnormal blood sugars if we do not take care of it. Now, today, I'm very delighted because I'm sure I was telling my colleagues from Wockhardt, in the recent times, we have been talking a lot about gliptins, SGL2 inhibitors, GLP-1 receptor agonists, their benefits, they're amazing drugs. But two most important drugs that have stood the test of the time over all these decades are insulin. We have been using insulin for the last 100 years. Now we are getting into 100 years plus. And sulfonylureas for almost 7.5 decades. And what sulfonylureas we used to use 50 years back were different from the ones that we are using today. Much safer, much better. No. And many times, whatever malice we associate with sulfonylureas originated from the data that was with older sulfonylureas, like chloropropamide, which has a half-life of 7 to 2 hours, glibenclamide. But today, sulfonylureas are much safer and much better. And the general endocrine fraternity and diabetes fraternity seem to be missing this point in this den. So, Anirban, I'm really happy that these two legendary drugs that have helped mankind for more than 100 years, one drug and another one which has been around the corner for 7 decades, we are discussing today. And another topic, what amazes me, Dr. Jesse Thomas, first time, listening to a real-time podiatrist in a meeting. We have heard them in minuscule presentations. But someone who has an experience of handling 7,000 diabetic feet, isn't that awesome? Isn't that amazing? See, we look at amazing people who do phenomenal work on coronary artery disease. We know of people who take care of the kidneys for decades. But people who are exclusively devoted to care of diabetic feet are relatively scant in this country. And Dr. Sankar just now told you in how many places she has been responsible for starting this facility. So I'm sure all of us are very keen to listen to these both speakers. For starters, I would invite Dr. Anirban Sinha, who, apart from whatever you have heard about him, is a very elegant speaker, is an associate professor in Calcutta Medical College, and publishes periodically very well. And I know I still remember, I was associated with the grant of that A.V. Gandhi Award more than a decade back to this young, brilliant man. Over to Anirban to start his talk.
Thank you, sir. Thank you, sir, for your nice introduction. And thank you, the organizers, for inviting me to talk on this unique points or this unique opportunity of talking on two very robust molecules for managing diabetes. And sir has rightly pointed out that these drugs are in the management of diabetes for years. So these drugs are actually very important, even if the newer drugs are coming in, be it a newer gliptins, GLP-1 analogs, or newer drugs, which are definitely has a role in managing diabetes beyond glycemic control. But definitely in the diabetes patients, first thing we think about is get a good glycemic control, because that matters most. So for example, in a hypertensive patients, cardiovascular outcome depends maximally on the cardiovascular blood pressure control rather than the other added benefits of antihypertensive drugs. So getting a good glycemic control is very important for an anti-diabetic agent to be effective. And for that, both insulin and sulfonylureas are actually time-tested legends, as we are discussing. And we know that insulin had been a boon to the mankind for survival of type 1 diabetic patients. Before that, 1921, not a single type 1 diabetic patient may be past their 20s and rarely 30s. And so we understand that it is almost a boon to the mankind that we got the insulin, and it is available freely at present. And we are getting newer insulins and more sophisticated insulins and more matching with physiological function of the body with the insulin. So we need, and the sulfonylureas, sir has rightly pointed out, we may not have seen the journey of initial part of the sulfonylurea, the glibencamides and others, but definitely the newer sulfonylureas we have seen, and we have used it in our day in and day out practice, and they are very safe and effective in our clinical hands. So we are going to talk on these two famous molecule, almost the legends of the management of diabetes. Next slide, please. So we have discussed these points like global prevalence. That has nicely pointed out our Indian prevalence data published in different journals. So it is increasing from 10.5 1921 to 12.2% in 2045, and we are actually crossing the China for the diabetic capital of the world. So we need to be more careful of managing diabetic patients and get a good glycemic control to prevent the complications of the diabetic patients. Because if the diabetic patients having complications, because they end up in more loss of wages and loss of daily productive life. So that is important to get a good glycemic control in a diabetic patients. So India accounts for 1 in 7 of adults living with diabetes. We understand how severe it can be. Throwing a stone in the road, maybe one person if you hit, 1 in 7 per chance it is going to hit a diabetic patient. And prevalence of people in 20 to 79 years, it's around 9.6%. So almost 10% of the population, the productive population of India, are actually having diabetes. They are expected to get the complications if not correctly corrected and getting a good glycemic control. Next slide. So coming to the guidelines from the real life practice, metformin had been a cornerstone of managing the diabetes, at least the type 2 diabetes patients, and it is not well tolerated in some type patients. Then we need to start with the other drugs, and sometimes metformin is not sufficient for the patient to get a good glycemic control. Then we add on the other drugs like sulfonylurea, insulin, and newer drugs like DPP-4 inhibitors, SGLT inhibitors, GLP-1 agonists. So point is that still the newer drugs like SGLT inhibitor, GLP-1 agonists are costly and may not be as effective as insulin. Definitely, we have talked about in our childhood, since our childhood student days, that we know the insulin can reduce the HbA1c of any level. Not a single anti-diabetic agent can do that. All the other anti-diabetic agents maximally reduce the HbA1c level of 1.5 to 1.6, at the most 2. But insulin can reduce the HbA1c of 3, 4, 5, and even HbA1c from 10 to 5 to 8, 6, something like that. So it is a huge potential of good glycemic control. And so is the sulfonylurea. It is less costly. And definitely these are not a point of concern of gastrointestinal disturbances, because we Indians take a carbohydrate-rich diet, and GI disturbances are as per very common in our population. And we added drugs like DPP-4 inhibitors or adding the drugs like metformin that increase sometimes the GI burdens. And sometimes they are so intolerant we have to withdraw the patient. So in this perspective also, both insulin and sulfonylurea is very safe and effective. It does not disturb the gut and also does not precipitate the pancreatitis or other secondary UTI or other infections like SGLT inhibitor can precipitate. Next slide. So increasing expenditure on healthcare is a diabetic subject in the developing countries had been a concern throughout the years, and there have been publications. As we can see, diabetes management poses a huge economic burden, because in India still almost 90%, not 80%, people pays from their pocket to get a good glycemic control. And even the hospitals, the state-run and the national central control hospitals still cannot provide the adequate medicines of all the levels to get a good glycemic control for all the patients. So that is the point where the glycemic control need to be more cheaper to the common man who come to our poor clinics who cannot afford all the sophisticated SGLT inhibitors or the GLP-1 agonists. Maybe these are very good drugs for add-on benefits, and they are definitely wonderful drugs, but cannot be afforded by common man of India. So that should be kept in mind when we prescribe a drug in diabetes. Next slide. Like coming to the two important pillars as we discussed, sulfonylurea, it was discovered way back in 1942 became available in 1960s. Second generation sulfonylurea offer good efficacy and better safety and widely used nowadays. As Sarah said, initial sulfonylurea had the hazards of precipitating hypoglycemia, precipitating other lactic acidosis and other in the metformin, like metformin, initial fenformins had lactic acidosis. Similarly, sulfonylureas precipitate the more hypoglycemias in the initial sulfonylurea, so which is not available and not used nowadays. So what we are scared of sulfonylurea is not available, the current sulfonylureas. So you should be remembering that when we prescribe a sulfonylurea. Similarly, insulin have been getting changed from years from 1921 to current days. Almost 1 decade has passed. So we have changed the patterns of insulin availability. The analogs insulin are available. Even the human insulins are available free of cost. In our student days, we have seen the bovine and porcine insulin, which has been out of phase now because they had some reactions and some concerns. So we have the human insulin is a much cheaper cost, and that is actually a boon to the mankind. Again, all the patients, it can easily get the insulin and get a good glycemic control from any HbA1c level. But honestly, as I said, the newer analog insulin may be more physiological to look at, but they are costlier. So we still have the human insulin, which are easily available at present and cheaper cost, which can be safely used in the most of the diabetic patients, even the poorer section as well. Next slide. Sulfonylurea are the time-tested agents. So glycemic efficacy, we have seen that there's a very busy slide. I'm not going in detail. So sulfonylurea and metformin provided the best HbA1c goal that is less than 7% in a systematic review of 218 randomized control trial, almost 80,000 populations, with the efficacy of around 50% in both, almost 40 to 50% in both. So these drugs are very effective in good glycemic control in a big meta-analysis. So it is not a single population study. Big meta-analysis also shows that these drugs has a good glycemic control in wide range of population, in wide perspectives of population, and this should be trusted on for future management of diabetes. Next slide. Next slide. Sure. Okay. Long-term efficacy of sulfonylurea. So we have seen that retrospective studies of tertiary diabetes centers that majority of the patients who have long-term diabetes, that is standard deviation of 23 plus minus 14 years, where on sulfonylurea as in monotherapy, around 65% of the patients, mainly glycoside and glimepiride, compared to the 43% of the similar mass patient of with the type 2 diabetes. So sulfonylurea could be effective and safe over a long period. So we are concerned about the sustainability of the efficacy of the drug. For that also, though initially we thought that sulfonylurea, because it stimulates the beta cells which can rapidly exhaust it, but definitely in the studies, analysis has shown that they work well even up to 20 years of diabetic patients. Almost 65% of the patient can still be on sulfonylurea with a good glycemic control. So that gives us assurance it can be used for longer term as well. Next slide. So safety of sulfonylurea, we are concerned about all CVOT trials with all the newer molecules because CVOT is the in thing, though recently FDA did not withdrawn the recommendation of mandatory CVOT trials for all the newer drugs or anti-diabetic agents, but still CVOT is a concern. On that perspective also, those sulfonylurea came in the market way before the CVOT concept developed, but still if we go for retrospective calculation, we have shown that managing macrovascular complications, well-established safety profile has been documented more than 60 years in the market, and meta-analysis of direct or indirect from 13 studies have shown that there's a good about glycoside and glimepiride are associated with the lower risk of all-cause cardiovascular-related mortality, whereas the sulfonylurea failed to show other sulfonylureas fail to show significant benefits. So what we commonly use in our practice is the glimepiride and glycoside. They are quite safe. We can see the forest plot. We can see glimepiride glycoside, though it touches the baseline, but glycoside definitely does not touch the baseline. So newer sulfonylureas does give a better management of CVOT outcome indirectly, though it is not a correct CVOT trial. Next slide. Safety of sulfonylurea from Carolina, though it was planned initially to non-inferiority trial, that shows that it did show the linagliptin and the glimepiride. Linagliptin was non-inferior or similar efficacy and similar cardiovascular outcome at par with the all-cause mortality as hazard ratio of 0.9, severe mortality and non-severe mortality all. So it is non-inferior. So initially thought to be, it is made as a beneficial of linagliptin, but a study did find out that there's a similar efficacy of mortality benefits both cardiovascular and non-cardiovascular benefit in the glimepiride compared to the linagliptin. So it gives an assurance that it is as good as linagliptin in cardiovascular safety profile and non-cardiovascular CV mortality as well. Next slide. Coming to the older studies, earlier clinical data to Carolina, like Wikipedia's, we all talk about this. Even these are before our student days, but still it is relevant. And Advance and Accord, they have shown that sulfonylurea is highly represented in intensive glucose lowering arms. No increased CV risk was reported by the investigator even way back to Wikipedia studies. Next slide. So sulfonylurea does not increase the risk of all-cause CV mortality. From the recent meta-analysis, 47 RCTs were included, almost 37,000 population. They've shown the odds ratio of 1.12 and cardiovascular was 1.12 infarction. So odds ratio was 0.92. So sulfonylurea is safe, and newer sulfonylurea definitely not associated with increased cardiovascular mortality. From the meta-analysis, as we have seen, 47 RCTs have been included, almost 37 big chunk of data of population, 37,000 people. Next slide. So newer sulfonylurea all-cause mortality, we can see compared to the repaglinide glabenclamide, we definitely so glimepiride or glycoside has a Kaplan-Meier analysis survival is much better than the repaglinide and glabenclamide, the older sulfonylurea. So it definitely gives an assurance that all-cause mortality is better with the less selectivity of beta cell receptors. Next slide. The risk of overall mortality in the patients of type 2 diabetes receiving glipizide, glyburide, and glimepiride monotherapy. So this is a study of 11,000 patients. Glimepiride may be the preferred sulfonylurea with underlying CAD. The study shows that glimepiride is the lowest 3 years mortality among the all three sulfonylureas in this current trial. So glimepiride at least as good as other drugs, or it's slightly better than other two as compared here is the glipizide and glyburide. Again, those are not commonly used at present, but glimepiride is slightly better than lowest 3 years mortality in perspective. Next slide. Safety of sulfonylurea, we are all concerned about hypoglycemia in sulfonylurea, as is the insulin. But honestly, if you can educate the patient well, and the newest sulfonylurea, significantly later generation sulfonylurea, as we are talking about, hypoglycemia is much less. And if the patient is educated how to plan the meals, how not to skip the meals, and then I personally feel in my clinical practice, sulfonylurea does not cause significant hypoglycemia. So is the insulin as well. If the training is correct, it does not affect the hypoglycemia risk profile. But we need to explain the patient about the management and factors which can precipitate the hypoglycemia. Next slide. Guidelines statement for affordability, accessibility, because nowadays all the countries throughout the world, even first starts with the NIH, that is British, they're funded by the government. So they found that care for the patient of diabetic patients, widespread condition of diabetes, cost effectiveness is very important because they pay from the government pockets. So in general, insulin, SGLT inhibitor, epiphane inhibitor, GLP-1 agonists are more costly than the metformin and sulfonylurea. So NIH guidelines still holds the sulfonylurea metformin as the first line for most of the diabetic patients for management. And really it works well in our country as well, as we have seen in the clinical practice. Next slide. Guideline statement of affordability and accessibility. So newer to drugs, and which does show that give a sulfonylurea in a patient of type 2 diabetes who do not achieve the glycemic control with metformin alone, who have contraindication to metformin, we can also use that as a first line agent. It's a WHO has developed a clinical guideline on this perspective. And this is now, we use this in unofficially as a replacement of metformin. Now WHO has come up with a guideline that it can be used if the metformin intolerant patient as a first line, especially in the cost concern is there, and then gives a wonderful outcome without significant hypoglycemia as well. Next slide. So guideline statement for affordability. So we know the Nielsen guidelines talk more about the SGLT inhibitor, GLP-1 agonist, but there are small caption there that considering the cost and access. And honestly, for the European people or the Americans, this may not be the significant factor. For as the Indian, cost, as I said in the very beginning, 80% of the patient pays from their pocket. There is no insurance coverage. So cost is very important for most of our anti-diabetic patients, diabetic patients, to be treated for long term, because it is a long-term disease process. It is not a single go of 2 months, 1 month therapy. It gives a good glycemic control required for a longer duration. Their cost is very important, and that perspective, again, guideline says the sulfonylurea, thiazolidinediones, and certain insulin, the human insulins, are very effective at good glycemic control without significant increase the cost. Next slide. So I've talked about this. Next slide. So place of sulfonylurea in the management of type 2 diabetes in South Asia, as I said, South Asian people had different food pattern, different genetic pattern. So we need to have a good independent guideline for consensus for diabetes management. Where it correctly says that cost is the important consideration in this region of the world, and sulfonylurea could be the oral glucose lowering agent of choice in these countries with low income setting countries of this population. So in this population, there is a definite guideline that we should be using these kind of drugs in the resource poor content or the patient who cannot afford the costlier medicines in the beginning. Next slide. Human insulin is the second reagent. As we are talking, initially we have talked about the sulfonylurea. We have realized that insulin therapy is mostly important when we almost 5 to 10 years of the diabetes period has passed in the type 2 diabetic patients and the beginning of the type 1. So when 50% of the beta cells are lost and fail to achieve the maintained HbA1c with any anti-diabetic agents, 3-4 anti-diabetic drugs added on, but still the HbA1c is now, if we add on the drugs, we can fail to achieve the good glycemic control, and then the insulin gives a good idea of getting the good glycemic control in this situation. And many patients of type 2 diabetes eventually require insulin in the long run, and that should be explained in the very beginning of the diabetic management. So insulin holds good in any situation, be it in the early stage when the patient has a sepsis, complications, or the patient cannot have a good glycemic control presence with the glucotoxicity. Then also we can start initiating in the very early stage, and honestly that gives a better advantage in the initiation of glycemic control. But in the latter part, when the insulin is depleted, 50% beta cell are lost, so insulin should be the only drug initiated along with the other drugs. Next slide. Insulin is a vital drug. As I said, 5.6 million insulin must take the daily management of diabetes, and they are affordable. And affordability is a guest concern for our people. As I said, family healthcare providers, all depends on the meager source of income. So affordability of simple human insulin works well. And the wonderful drug of insulin, and it works very well for any HbA1c level, as I said in the very beginning. Next slide. Cost-related insulin underuse among the patients with diabetes. There are studies have shown that around 25% of the type 2 diabetes patient confess that cost-related underuse of insulin because they cannot afford it in the costlier insulins, maybe the better insulins, but still they're costlier. Around 66% of the individual faced hardship on purchasing the diabetes equipments. Wide cost barriers have been documented, and poor glycemic control were patient with a cost-related underuse among the other patients. So all these factors have been documented in the studies. This is published in the JAMA Internal Medicine. So these have been known facts in our clinical experience, as well as a published data, that we need to get a good glycemic control with a cheaper price. And there's the insulin, the human insulin comes a very big role without adding the designer insulins. Next slide. So patients skip the insulin dose because of the high cost. We all the same thing. This skimming of the insulin 3 times more likely to have poor control, and patients sometimes do not disclose it when they visit you. So we need to take a hard history, repeated asking the patient that whether you really miss the insulin, whatever happens. So this takes a very important factor for managing diabetes. Patient was increasing the dose of insulin, but we end up in higher glycemic levels, 300, 400 blood sugar. And if we keep on asking the patient, then we realize the patient is actually not taking the insulin or reduce the dose of insulin on their own. That did not disclose to the clinician. So these factors come in. So insulin should be cheaper to use it more frequently with all the population of our country. Next slide. So insulin is included in the list of essential medicine for WHO and should be available all times at the price of individual of the community can afford. That was the WHO goal, and it is really available in our country with a cheaper price. Next slide. ADA comes to prescribe the lowest priced insulin required to effectively and safely achieve the target goals. And providers should be aware that rising cost of insulin preparations, now the negative impacts on adherence to the clinical treatment, as we see in the clinical practice, we should keep it in mind when we ask the patient to take the insulin. We ask the patient their affordability first, then write the prescription. Honestly, I do that whenever I write any drug. I ask the patient whether you can continue it, because asking the patient to write a drug, patient says, okay, I can take it. But if I tell them you have to take it for your lifelong, patient may hesitate, and there comes the picture of whether the patient can afford it or not. And that should be clearly explained to the both clinician and the patient that what they can afford and what can be continued for lifelong. So then we choose the drug wisely. Next slide. So here create the greater transparency among the supply chain to understand the rising insulin cost and limit features list of price increases in the rate of inflation, allow the government negotiation to drug price. So these are all nitty-gritty factors we may not be understanding as a clinician, but rebates, past savings, and expedites the approval of the insulin biosimilars. These are government regulations. Biosimilars becomes cheaper, and so it should be approved earlier by the government, so make it more available and cheaper cost to the common people. So all these factors should be kept in mind when you prescribe the drugs. Next slide.
Anirban, a little faster.
Yeah, I just finish it up. There is nothing new to say that. So when you compare the insulin to the analogs, we see that their comparable insulins are available. They work almost well, and so we need to be used. Next slide. Basal insulin versus other analogs. Again, the newer insulins are costlier, but basal insulin is still the gold standard when we compare any drug, any long-acting insulin. We still compare with the glargine, and so glargine remains the gold standard for managing the long-acting insulin. So it should be used widely compared to the newer insulin when the patient cannot afford it. So that should be kept in mind in the one single line. Go on, next slide. Next slide. Yeah, long-term acting insulin analog versus NPH. They have shown that in long-acting insulin analogs in the type 2 diabetes does not seem to provide a better glycemic control compared to the NPH insulin. NPH insulins are much cheaper compared to even the glargine. So NPH insulin works well if we give twice daily. So it should be prescribed adequately to get a good glycemic control in the cost-concerned patients. Next slide. I think I end my talk here because most of the things are same. The comparisons of safety are almost similar of both the costlier drugs versus the cheaper NPH insulin and the regular insulins. So in practice should be modest compared to the NPH insulin. So it should be more useful and should be commonly used in our patients. Next slide. Next slide, please. Keynotes. So GLP analogs and basal insulin. These are the meta-analysis. Comparison, again, we show the 10 randomized trials and compared to the regular insulin, newer rapid insulin, minor glycemic advantage, which is not significant when you consider the cost of the medicine in the patients. Next slide. Efficacy is almost similar. It's as good as the newer analogs. So again, in the efficacy wise, it is equally effective with a much cheaper cost. Next slide. Go on, next slide. There is nothing. Okay. Premix insulin versus other analogs offers, again, the analog insulins offer little glycemic advantage compared to the adequately titrated insulins of basal and bolus. So if the patient can willing to continue the basal bolus or NPH premix, they are equally well compared glycemic control compared to the newer analog insulins, though they may be slightly compared to the hypoglycemic slightly better. But if you explain the patient properly, almost it is similar and much cheaper cost again. Next slide. So this is the ADA statement of cost consideration. Now even the first world countries are understanding the importance of cost consideration, and here they say that cost concern human NPH insulin and regular insulin may be appropriate choice for therapy, and clinicians should be familiar to use it. So even the ADA are talking about this. So older insulin, the time tested insulin, they can work wonder. I'm not going in details. Next slide. Next slide. Hello, next slide. So I end my talk here because of the time. I cannot talk about more, but in general, that cost is important for our country, and all the insulins which are cheaper are equally effective if we use it wisely. Over to sir, Dr. Jarga sir, please.
I think, he gave the real crux of what we wanted to know today. You see, he did talk about sulfonylureas, as I said earlier on. Two things. One of the first cardiovascular outcome trials was on sulfonylureas in 1960s by a university data group, diabetes data group sponsored by NIH. And that time, a tall butamide and tall azomide were found to be cardiovascularly not safe. And unfortunately, that stigma continued till recent times with sulfonylureas when the basic molecules were different. And today he very unambiguously talked about the Carolina trial, while, linagliptin, one of the safest gliptins, was compared with glimepiride, and results were amazingly, surprisingly equal, even in terms of sulfonylureas, in terms of cardiovascular events. So this needs to be reiterated that yes, today's this molecule is totally different from what was the molecule structure, functionality, duration of action 30, 40 years back. And second important thing, the most important thing, if you want to reduce any target organ damage, first thing to do is reduce the hemoglobin A1C. And two most powerful agents to reduce hemoglobin A1C today available are sulfonylureas and metformin. Another band, they talk about the Wikipedias. Every time you drop HbA1c by 1, there's a reduction of almost 1/4 in the prevalence of microvascular disease. So those factors cannot be neglected. Second, insulins, before the discovery of insulin, average life expectancy of a type 1 diabetic used to be 6 months to 2 years. And today they almost, if taken care of right from the beginning, can achieve a near normal life expectancy. And we used to have problems with bovine and porcine insulin that Anirban talked about. But with these recombinant insulins that we have been using, these human insulins for the last 3.5 decades, scenario has been totally different. But the bottom line of this talk has been, one, that write a prescription that will be respected for a long time, because it has economic ramifications. Somebody has to spend money from his own pocket, and that pocket needs to have that money. He very nicely, elegantly said that we write somebody insulin. Then suddenly he misses one dose because he wants that one dose to last longer because there is no money. Or he makes 30 units, 20 units only because he wants that vial to last longer. It should not finish in a few days only. So the role for, I am sure that there are many questions that are coming up. We'll take them together. We'll take them at the end during our discussion. Now it's my pleasure to invite our second speaker, Dr. Jesse Thoms, who is a podiatrist, who was already very elegantly introduced. And most amazing thing was that she has established diabetic foot clinics on many places and has been responsible for managing 7,000 feet, which were sick because of diabetes. And today she is talking about the role of a levonorgestrel in the management of diabetic foot infection. Dr. Jesse Thoms, is she around?
Can you hear me?
Yeah, ma'am.
Yeah, I'm just sharing screen.
We would love to see you as well, ma'am.
So yeah, I'm just screen. Sorry.
Sankit, you can present the slides and ma'am can.
Sure. Nirav, have you given ma'am the sharing rights? There, yes.
Yeah.
Wait.
Ma'am, we can see the screen, but not the presentation.
Can you see?
Ma'am, we can see your Windows folders, not the presentation.
Now us.
Can you see?
No, ma'am, you can stop sharing and reshare your screen so that we can see what's on your screen which you are looking at.
Yes. Share screen. Yeah. Can you?
Not yet
No,
started.
ma'am, not yet.
Sanket, do
Do
you
you
have the
want-
slide set on your desktop there?
Yeah. I've sent it to Ravi Gavli also.
Dr. Ravi, would you be able to flash the slides at your end?
I try. What I do, I forward it to you. Wait.
I'm really sorry about it.
No problem, ma'am. I'll
It's
share
not
it
my
as soon as I
laptop.
receive it.
Dr. Sanket, Rahul here. If it's possible, you can share it. Give it to me. Acha, it's possible. Fine, okay. Otherwise, I would have shared it. Yeah.
Yeah, anyone who can do it.
Can you?
Ma'am, I'm just waiting for the slides to reach me from Dr. Gavli.
Dr. Sanket, I can share the slides if you want. I have the slide open in front of me.
Yes, please go ahead. Please.
No,
Please
I have. I've done. Did you get it, Priyanka? I've sent it to Dr. Gavli.
Ma'am, I also have a set of the slide deck unless you have changed
No,
something in
I've
that.
changed. I've changed the whole thing.
Oh, is it?
Madam, I haven't received from you. Probably you sent it to wrong email address. In which ways, you please try sharing your screen. It will be. Or easy. ma'am, I'll just put up my email address, ma'am. I'm Rahul Dave. You can share to me. I'll share the slide. I'll just put up in the chat box, ma'am.
Yeah.
Okay, my email address. By that time, you can start, madam.
Yeah. everybody, and thank you, Team Wockhardt, for having me here as a speaker. I'm extremely thankful to the team for making me a part of the summit. And it's my pleasure to talk about a much awaited drug in diabetic foot. So why are we here to talk about this problem? Naturally, it's the magnitude of the problem. We have 17 million diabetic patients, 15% develop diabetic foot ulcer. Out of this 15%, 74% of them land up with major limb amputation. And 80% of the major limb amputation are preceded by biofilm. For doctors who are not familiar with this terminology, I'll be explaining in the next few slides. When we talk about infection in diabetic foot, it's very costly. It's a very severe and costly infection, or rather a complication of diabetic foot compared to the cardiac or the nephro or the ophthal element of it. So we need to address to it seriously. What makes diabetic foot infection difficult to treat? All of us know about the triopathy. Now, when we talk about the triopathy, the immunopathy part, the immunopathy is the leukocytes which are there for various reasons, because of persistent hyperglycemia, they have impaired phagocytosis, they have impaired chemotaxis. So when there is a microbial attack, these leukocytes cannot work to their optimum like a normal individual. And the neuropathy element of the feet is shown that there is a low inflammatory cell accumulation here. So they cannot deal with an acute bioburden there. So these ulcers tend to go into chronicity. The third, we all know the vasculopathy, the blood flow to the limb is less, the oxygen is less, the perfusion is less. All put together, there is an enhancement of infection and the bioburden. So for this is a basic pathophysiology. The moment a bacteria is invaded, what happens is the neutrophil reach there. In a diabetic foot ulcer, the first line of defense, like any other limb, it is the neutrophils. So the neutrophils first, the granules in the neutrophils degranulate, and then they attack these microbes. Then the leukocyte, the remaining leukocyte absorbs the local oxygen there, and there is a phagocytosis which goes on, and there is an oxidative killing. This is very important, oxidative killing. So the oxygen there is used up, and there is a lot of hydrogen peroxide, hypochlorite, which is produced, which kills the bacteria. Meaning, most of the oxygen there is used by leukocytes, and the wound is deprived of oxygen, and the wound becomes hypoxic. So there is a hypoxic wound. The supply is limited because of vasculopathy, neuropathy, etc. The bacteria there uses up the oxygen. So there is a mismatch of oxygen in the wound. The demand and supply, there is a mismatch, and this leads to active infection. So now there is a poor blood supply. As such, there is hypoxia in the leg, which because of the leukocytic action, there is hypoxia in the wound. Oxygen consumption supersedes delivery of oxygen, like what I explained. There is a lot of biological activity which is going on in the wound, like killing of bacteria, oxidative killing of bacteria, reconstruction of new vessels, connective tissue, proliferation of fibroblast. All this requires oxygen, but oxygen is less. So there is, in chronic wounds, there is biofilm, which I will be explaining in future. This biofilm again reduces overall level of oxygen in the wound. And so we need something aggressive here to deal with the microbes, so that the oxygen present in the wound is not utilized for killing the bacteria. They are utilized for healing the wound. So how do we go about it? We need a good antimicrobial protocol. So This is the protocol suggested by in the International Wound Care Journal, which clearly says antibiotic has to be restricted to spreading infection and systemic infections. Local infection needs local antibiotic or local antimicrobial. A stage of contamination and colonization doesn't require antimicrobial. So for people who are not familiar with the wounds, I have got a few pictures here. The first two pictures shows a contaminated wound and a colonized wound, which doesn't require antimicrobial. The third picture here shows that there is a colonization, but not so critical. The fourth picture is a critical colonization. A wound in the third picture suddenly starts exudating more, suddenly looks pale, suddenly starts smelling. So this is called critical colonization, where this limb requires antimicrobial therapy. And the last one is a spreading infection, which definitely requires systemic antibiotics and a good debridement. So this is contamination, colonization, critical colonization, and spreading infection. The next important thing is a biofilm, which again, this is one of the biggest problem right now what we are facing in diabetic foot infection. It said that 80% of the chronic wounds have biofilm. So what's a biofilm? So these are microorganisms which has got the small hair-like structures. Can you see that? They are called the pilae. They go and get attached to biotic material like human soft tissue, and also they can go and get attached to catheters and prostheses and all that. So these this microorganism with pilae, they have a signaling called as quorum sensing. They give signals to the neighboring microorganisms. They form a group and they get embedded in a substance called extracellular polymorphic substance. What is this extracellular polymorphic substance? What does it do? It prevents, these microbes get protected from host immunity. That's leukocytes cannot act on them. And when we give a systemic antimicrobial or some local antimicrobial therapy, they are resistant to that also. So it's a very difficult problem what we are facing, and we have a lot of local antimicrobial therapies which are fighting with these biofilms, which and one of the antibiotic which was always there, which could have fought with my biofilm, was gentamicin. And now we have this new drug levonorgestrel, which has come to our rescue. So this is one of the picture of biofilm. Can you see such a small wound? But this can take years to heal because host defense is not working. Systemically, we cannot use any antibiotic which can fight the microbe, nor can we use anything locally, or whatever is available has to be consistent with fighting with biofilm. So when we talk about diabetic foot infections, this is a potentially disastrous, rapidly progressing infection into deeper tissues. Most infections are polymicrobial, require more than one antibiotic. Patients with diabetic foot infection also have multiple other comorbidities. As we all know, the renal element is, mostly it's the foot, kidney, eye syndrome. So renal element is very prominent, and sometimes even hepatorenal when patient is in sepsis. So we have lot of limitation while we prescribe an antibiotic. We have to titrate according to their renal and hepatic parameters, and the patient certain oral drugs when patient is in sepsis or when in an infective systemic infection, they have severe loss of appetite. So oral drugs we have limitation in giving oral drugs. The spectral coverage also is not optimum. So hence the choice of antibiotics would be broad spectrum coverage, which doesn't require more dose modification, which has got similar bioavailability, injectable and oral, while switching from IV to oral. And it should have preferably an action against biofilm, that if not asking for more. And overall, it should be safe. So in India, when we look at diabetic foot infections, if not treated promptly, I told you 75% or 80% of the diabetic foot ulcers can go into major limb amputation. We have a polymicrobial flora in the wound with gram-positive Staphylococcus aureus even now play a very dominant causative role, because they are not only gram-positive, they are also facultative anaerobe. And I told you in diabetic foot there is less of oxygen, hypoxic wound, so they just behave like an anaerobe. So and again we have this methicillin resistant Staphylococci aureus, which is at present it says 10 to 32% of diabetic foot infections is associated with higher rate of treatment failure, morbidity, hospitalization. It's become a big nuisance, the MRSA. I think all of us are facing it. And you can see from 2016 to 21, there is a steep rise from 28.4% to 42.6%. And we were, the drugs, I'll be talking about the drugs which is at present what we are using for treatment of MRSA. All these drugs have got their own limitation. The first thing is all of them are bacteriostatic. Linezolidine, when given orally, they have got severe gastrointestinal symptoms, mucositis, they refuse to eat, they have a barely narrow spectrum of coverage. Tigecycline, again bacteriostatic, require a severe dose modification in hepatic impairment. There is, like once patient is being discharged, there is no oral formulation. Clindamycin again is bacteriostatic. Diarrhea and Clostridium difficile colitis, we all know about it. Vancomycin also, we are worried about the nephrotoxicity and its so slow bactericidal action, limitation with oral formulation. And daptomycin, of course, I've not used much. So my experience with daptomycin in MRSA is limited. So considering a diabetic foot infection, where we mostly the gram-positive coverage, what we require is for Staphylococcus aureus, strepto, MRSA, and we were, probably MRSA is the most difficult to treat as of now. So this drug levonorgestrel has got a good bactericidal action. It's excellent biofilm activity, broad spectrum activity against most of the gram-positive and quinolone-resistant gram-negative or microbes. And most important is very easy shift from IV to oral formulation, excellent bioavailability of more than 90%, and most important, superior safety. No thrombocytopenia, no QT prolongation, no renal and hepatic enzyme, even after using for 3 to 4 weeks in my experience. So my number of patients I have used in the past 1 year could be close to 20 patients. This is one of the recent case which I would like to discuss, very interesting. She was a 55-year-old female who came to me with low-grade fever, loss of appetite, severe mucositis, severe pain in the foot, the right heel. You can see the wound. This is post-operative. Poor blood sugar control. Her hemoglobin on admission was 8.5, which was corrected before surgery. She came with a WBC count of 18,000, creatinine of 1.4, very sick looking. X-ray foot showed no osteomyelitis. Arterial Doppler biphasic showed biphasic flow with generalized atherosclerosis. Transcutaneous oxygen pressure monitoring. This is one of the method where we decide whether there is enough skin perfusion. It says anything above 30 or 40 is a healable wound with little push. Something below 20 needs intervention like angioplasty or revascularization technique. So the culture before admission, like she was debrided 3 times before she came to me in a span of 8 days under anesthesia, and culture done then showed E. coli. So after discussing about the diabetic foot, the characteristic of diabetic foot, what happened with these 3 debridements? Every time the wound was debrided, there was there was an influx of leukocytes and usage of oxygen. So the wound was deprived of oxygen, even though it was a fairly good blood supply. The wound was hypoxic. So this was there in my mind when I took her for surgery. And also this wound, like the dressing was very poor, meaning in the sense it was not a very comfortable dressing, not a very sterile dressings when she came to me. So I also expected some amount of gram-positive infection, mostly staphylococcus in these cases where they are also facultative anaerobes. So all this was in my mind. And in diabetic foot, we say heal never heals. So, I am always very strict about dealing with a heel patient. I always offload them. Even while lying down, I give them instructions. The heel should not touch the bed. And it's a very difficult wound in terms of when we talk about diabetic foot. So present admission, she was debrided again. Creatinine within 24 hours came down to 1.1 from 1.4. WBC reduced to 16,000. There was no fever, but appetite was status quo. Considering that she was debrided thrice and there would be hypoxia, I started her off with hyperbaric oxygen, but the pain persisted. So this was very difficult for me to explain. The pain was the same from day one. It was the same, even after debriding, even after blood parameters showing that she was better, no fever. Of course, appetite was reduced. So then, since I had already expected there could be a gram-positive staphylococci, I started off with MROC. Pre-operatively, I mean, immediately within 24 hours when her pain did not reduce.
Dr. Jesse, you have to be a little bit faster.
Sorry, the culture showed enterococci. Sorry, sir. Enterococci showed, the culture showed enterococci fecalis. Anyway, the gram-positive coverage was good. WBC reduced, creatinine came down to 0.8, and the pain continued. This is when I used an innovative method. I made antibiotic calcium sulfate beads, which was much below the desired dosage. 3 ml contains only 24 milligram, but I made beads, I put it into the wound and the pain subsided. So local antibiotic treatment of levonorgestrel here helped. So this is the dosage what we recommend when the IV and oral with same bioavailability. You can see the same bioavailability with IV and oral. This is the broad spectrum of bacteria which is covered with levonorgestrel and with very less or no side effects or no dosage adjustment required in renal and hepatic. Thank you for patient hearing. And I'm sorry for all the initial glitches, and now still continues to be the same.
Technology has a unique way of caving in.
I'm really sorry about the whole thing. I don't know. I'm just trying again if I could share my screen. If not,
I think we had some wonderful concepts in the last 15-20 minutes. Firstly, talking about that biofilm and how it deprives the tissues of oxygen and how it will be handled.
Yes.
Something that probably, many of us would have understood better today for the first time.
Well, thank you.
When somebody has a diabetic foot, she very elegantly said many times it is not diabetic foot alone. If you look at that first person, creatinine was already 1.4.
Yes.
And many of these patients will have concurrent diabetes-related comorbidities.
Yes.
It would also complicate many issues and make management difficult. And you saw, all of us saw those awesome feet, terrifying feet. I'm just like, something that must have been neglected, not for a day, not for a week, probably for months. And the sort of, I think it will be a microbiologist's dream to culture new stuff from that. And multi-drug resistant bugs coming out of it.
Yes.
Awesome. Coming down, I don't think, is Anirban still with us?
No, sir, he had some commitments, so he had to leave, sir.
There are a couple of questions that had been asked to him. Maybe I take them over. The first was, in the contemporary world, can we say that human insulins are better than analogs? No, nobody said that. We only said that probably the benefit in terms of hemoglobin A1C is similar to analogs. Analogous duration of action might be slightly different. The postprandial might be covered different because if you have a shorter acting component of it, like, a regular insulin which operates, let's say Insulin 30/70, which operates 4 to 6 hours. But if another one where there is Lesipro or there is Aspart, it gives a peak at 2 hours. But in totality, it has been shown it does not make a huge difference, except one cost is 2 to 3 times more than the other one. Yes, people can have that insulin, but point always is the money comes from the pocket, and this money has to come from that pocket for a long time. If money is not the issue, one can continue taking it. Then second very relevant question was about longer acting insulins. I think this is a very relevant question. When you compare NPH with a drug like Glargine or Detamar or Degludec, understandably, NPH of any formulation is not a 24-hour cover for a longer insulin. Many times that longer acting insulin NPH may need to be given twice. But then the point is, when we already give premix insulin morning, evening, these 2 doses of NPH sort of overlap each other and give a 24-hour duration of action. But if we need to give a basal insulin alone, Detamar or Glargine or Degludec are going to be truly 24 hours longer acting insulins. NPH would not be. And then there's another guy who had asked a question, a very relevant question again. Insulin and weight gain. Say that, many times we are working very hard to reduce people's weight. Now we have seen that insulin, after insulin, people start putting on weight. Very good question and very relevant observation. Many times what happens, when you deprive body of insulin for a long time, you see, like those diabetic feet, if such a person needed insulin, probably, he would run away from the doctor for a pretty long time. And, if you cannot treat a foot like that for such a long time that it gets so sore, an injectable therapy would not be sellable concept to such people. But at the end of the day, when you are deprived of insulin, you actually lose, you get cachectic. You get negative metabolism, catabolism. So you lose weight. And when you get properly insulinized, first thing is you start feeling filled up because that lost weight is getting taken care of. But yes, apart from this, the conventional insulins make one person a few kilos of weight. And many of us do simultaneously combine it with metformin in patients with type 2 diabetes mellitus. And if it's a problem, or if affordability is not a problem, also combining it with a cheaper SGLT2 inhibitor. And then, probably they will counterbalance the whatever weight gain has been there. Jesse, Thomas, there is a couple of questions. Yes, with all these procedures, you also talked about revascularization,
yes,
in resistant feet. Yes. In what percentage of people do you think, one, this revascularization would need to be done? And second, that this revascularization will be successful, because we know we have for a long time underplayed the possibility of peripheral vascular disease in our country.
Yes.
Because, routinely we would not do ultrasounds, we will not do Dopplers. And
Yes.
in fact, even my whole generation would only get an X-ray done to find out if there is a vascular calcification. And you can imagine, by the time a person will get vascular calcification, how long the vessel must have been sick.
Yes.
So the question is, what percentage do you believe would be helped by the revascularization?
So in my practice, something above knee, that is a occlusion in the SFA, superficial femoral artery, or the large vessels, I don't think twice. I just subject them for an angioplasty. But when it is a below knee disease, if I am I also do a transcutaneous oxygen pressure monitoring. If at all the blockages happened over years, what happens is they do have good collaterals if the patient was active. So if the TCPO2 is somewhere above 35-40, what I do is I do not revascularize. I subject them to hyperbaric oxygen. But if it is a posterior tibial occlusion, and if the area I am operating is the sole of the feet, and then I would prefer an angioplasty, considering explaining to the patient that this is not going to be a permanent solution. This might recoil, and I'm using they are using a balloon angioplasty, but this is just to cross the bridge.
Absolutely, to give some bridge over time. I think, Sanket, we have already crossed the time. We're already almost quarter to 9. Over to you for some final words from the organization.
Thank you, sir. So for the last and the final vote of thanks, I invite our marketing head, Priyanka, to give the vote of thanks. Over to you, Priyanka.
Thank you so much, Dr. Sanket. And first of all, let me share with you, today we were joined by around 700 delegates who were seeing the session all over the country. So that's how the audience response has been. So first and foremost, let me say a big thank you, Dr. Zagar, because without you, this session wouldn't have been really possible. And you're a very accomplished clinician and academician. It's always an honor to hear you speak.
Thank you so much.
Thank you so much, sir. And I must say thank you to both our faculties, Dr. Jesse Thomas and Dr. Anirban Sinha, who did a fabulous job talking about all the molecules that we discussed today. And I must say thank you to Dr. Sanket also and Dr. Ravi, who are heading our medical team and who were the people behind this entire show, and Dr. Alpa, who was coordinating for the entire program. And let me also give a big heartfelt gratitude to our leaders, Mr. L.C. Sri Vishnu and our president, sir, Dr. Amrit Medikar, sir. Because without their guidance, we cannot take even a single step. So thank you so much. And last but not the least, my field colleagues, because they are the ones who actually go out, talk about the program and invite all the delegates. So thank you all. Thank you so much for making this program very, very successful. Let me also just take a moment to highlight few of our products from Wockhardt that we have. So this session was brought to you by Wosulin and Glimade, along with MROC. So Wosulin and Glimade are the legends of Wockhardt. Both have completed 20 years, and Wosulin happens to be first Indian biosimilar insulin. So that's how about it. And MROC is our new kid, and we are trying to reach out to new patients and new HCPs for sale. So thank you all. Thank you so much for spending time with us and making it a big, big scientific piece. Thank you so much, and good night.
Good night.
Good night, all. Thank you, sir.
Thank you, Dr. Abdul. Thank you. I'm sorry I'm not able to show my face to you, but it was a pleasure meeting you.
Next time, maybe.
Priyanka, you're talking about the insulin and Wosulin.
Yes, sir. Yes.
When you guys made insulin, President Abul Kalam came to Aurangabad.
Exactly, sir. Correct. He was the one who inaugurated that plant.
And you will be amazed to know that insulin was made by a Kashmiri for Wockhardt.
Oh my God. So that I was not knowing, sir. If you could mention the name, that will be.
You can get
okay,
Thank you so much. Good night.
Thank you so much.
Good night. Good night.
Good night.
Good night.